Okay. Jean?
Would like to thank the Belgian AIM Group for proposing me and inviting me for this presentation. People who know me for a couple of years knows that I have a passion for preserving the joint, and it was the title of my thesis. Osteotomies can be of a help, but are not the miracle product that we have when we put on a prosthesis. To have a normal joint and to avoid problems like trapeziometacarpal arthritis, you need a normal inclination, a normally developed horns, lateral and medial, a normal Bacon score, and a normal cartilage quality. I mean, that is a whole menu to avoid problems with your thumb base. The slope of the trapeziometacarpal joint has been described first by Bettinger and Linscheid in 1999 and was taken over in 2002 by Adalbert Capangin, who described his so-called angle de dévers, his slope angle, which should be, when measured between the articular surface of the trapezium and the axis of the second metacarpal, around 129 degrees with a range of 6 degrees. Bettinger and Linscheid have proposed just the same, but with a complementary angle, the alpha angle in Robert's view. The difference between Robert's view and the Capangin frontal view is just the same as the difference between America and Europe. Cartilage quality is genetically linked. We know that if your father and your mother have a lot of arthritis, you will have a lot of arthritis. But women are more likely to develop trapeziometacarpal arthritis compared to men. When we examine a trapeziometacarpal joint, as emphasized by Anne Lejeune, you should be sure that you don't have a hyperlax joint, because hyperlaxity is prone to problems sooner or later, even in the presence of a normal slope of your trapezium in the frontal plane. We have already seen this a couple of times this morning. The pressure of 1 kilogram turns into 42 kilograms at the base of the trapeziometacarpal joint. What maybe has not been emphasized is that we don't have a congruent joint. Everybody sees it as a saddle joint, just like an Amazon driving a horse, but the contact surfaces are very small and depend on the type of pinch you are doing. Here you see the illustration of the pressure forces on the trapezium when you perform a key pinch, a jar grasp, or a jar twist. The cantilever turns or translates the base of your first metacarpal on a total different surface and is not well equally spread over the whole surface. This is an important feature that we should know. Well executed x-rays. I have many times fellows which I have trained, which come to me, can I have your presentation about the x-rays and how to perform a correct x-ray? You need to have well executed x-rays. And the only one who knows how to make a good x-ray is yourself. So you should train yourself how to make perfect x-rays in order to train the radiological department to have your perfect x-rays showing the joint space in all different possible angles and with or without stress. Illustrated here by a subluxation of the right trapeziometacarpal joint, illustrating a degenerative, painful trapeziometacarpal joint based on dysplasia. We like to operate, but our main goal is to remain conservative. As emphasized by CHJ in his thesis last year in Erasmus, about 50% of people we see at the clinic, 15% of the people we see at the clinic will be operated 1 year after all possible conservative treatments. And this will include a custom-made, I'm a very big fan of custom-made splints, because they are unique, because our patients are all unique in their morphology. Painkillers, together with paracetamol, taking them both together, if they tolerate anti-inflammatory drugs, is the best possible pain killing. And functional hygiene. I call this a treatment platform spread, which is supported by those 3 pillars. What do we do if it doesn't work? Well, we should be sure that our joint is still good enough to preserve it. If you are not acquainted with arthroscopy, which gives you the best information of the good parts and the bad part, as you've seen on this video, you can use an arthro-CT. A well-performed arthro-CT gives you a good topography of the quality of the joint. Different types of osteotomy can be proposed depending on the type of arthritis and normally morphological variance you have. The principles of osteotomy apply here as they apply everywhere in the hip and in the knee, is to spread the load to the unaffected part, try to restore the anatomy in case of congenital dysplasia, or restore the anatomy in case of post-traumatic change of the joint. This is an illustration of a Dell stage 1. And to be honest, I did that some bit, not a lot in the past, but when seeing the evolution after only 4 years, you see that abduction osteotomies, as described by Wilson, do not give a long-term good result. They are only possible in people having no dysplasia, no dysplasia of the trapezium, and no hyperlaxity. Addition subtraction osteotomy in case of subluxation of the base of the first metacarpal due to dysplasia of the first metacarpal. You can do this osteotomy, which has been described already a long time ago, and we are publishing in the Journal of Hand Surgery of American volume soon the results at 10 years, which remain good. Other solutions have been proposed as the door procedure by Jean-Luc Roux, which is a vascularized, technically very demanding solution. But I think the addition of subtraction osteotomy is still a good indication for the instability due to dysplasia of the trapezium. This is the way it goes. Don't forget one thing, because maybe we should not forget that we should go to an anterior approach, because the anterior approach gives you the best quality of vascularization. We published about that, and I have had a case report of Dr. Rimbaud from Angers, who reported a necrosis since he performed a dorsal addition subtraction osteotomy where the trapezium necrosed secondary to the osteotomy. This is a good illustration how it evolves. If you believe me, this was a person with the same view at the right hand and at the left side. We performed an addition subtraction osteotomy. What you see is that we had a translation. We don't have a translation anymore of the base of the first metacarpal. The angle, which was convex to the radial side, became concave to the radial side, and the stability was restored in this nice illustrative case. And finally, Van Rooyen published a nice technique about the solutions we can have with missed Bennett fractures. Missed Bennett fractures have the problem that they augment the discongruency of the base of the first metacarpal with the trapezium. You see clearly what's happening. It is the base is pulled proximally by the abductor, and we have a space that is created and fills up with bony material, bony callus. The proposed technique by Van Rooyen is a technique where he removes the callus, closes the wedge, and performs a trapeziometacarpal osteosynthesis. This is the illustrative case shown here perioperatively. You see the, you see this step off. This is the proximal part. This is the distal part. We don't want this. You remove it and see what you get, a perfect congruency. And an evolution in the cases he published in the surgical techniques of the hand and upper extremity from 88 to 7, which is dramatically better. Thank you for your attention.
It's up to me.
Okay.
It's up to you.
Okay. Hello, Jean.
Salut,
Hello, Anne again, and hello, Joris. So we all know the, excuse me. It's okay. I tried to change. Maybe this. Okay. We all know the evolution of surgical treatment of CMC1 arthritis during last decades since Patterson and Jervis. I always mention Patterson because his article was 16 years before Jervis. So Patterson and Jervis and now total prosthesis are in Europa, one of the modern options, as you know, for this surgical treatment. But with one important consequence, actually, indication for patients younger than before. In my first communication, I described my main reasons in the choice of TM prosthesis in CMC1 arthritis. And when we consider younger patients, 3 of these reasons still seem still more important. First, the anatomical. When the trapezium is out in case of failure, as you can see on the left, for a young man, it's difficult to treat this with shortening and Z deformation of quality. Okay, after prosthesis is always a problem, but I think it's a reason to think why put a prosthesis in young patient, because in case of failure, the revision may be easier than after trapeziectomy. The quality of bone for younger patients is also a better point for implants fixation than for older people, as show us Anne in this communication. For younger people, restoration of strength is very important, and total prosthesis provides a point of support between the first metacarpal and trapezium, and is for me the most logical solution from a mechanical standpoint. Third of this reason is critical. There is no or short immobilization, safe rehabilitation, and return to activities is rather short, and we can compare the comparison with of Seri and Gomez last year is significant. Another reason to insert prosthesis for younger people is that results of all types of prosthesis improved with long-term follow-up now, and comparison with trapeziectomy is most of the time, we can have to say, actually in favor of prosthesis. So it's now an indication we can propose for younger patients. But for this population, we could fear higher level of problems due to good quality of early results, and patient is utilizing his prosthesis, and return to potentially higher stress activities. The level of dislocation is allowed for most of types of prosthesis, and improvement with the principle of double mobility actually. Loosening of the cup remains a problem with long-term follow-ups, is sure. But in the general population, as you can see, this it's rather acceptable as every prosthesis. But we have to wait now if, as for the hip prosthesis, the principle of down mobility may decrease the constraints between cup and bone and so diminish the level of loosening. One of the problems for me remains in this population, deformation and wear of polyethylene due to low thickness and the quality of polyethylene. There is few analyses concerning younger people, but I found this one, and I think that wear of polyethylene will maybe a problem for this population. That's why for younger people, models with increase of thickness and new types of polyethylene are or will soon be disponible. What about revision? Results of all types of prostheses improved with long-term follow-up, as you can see. Now you can say that with these modern types of prostheses, we can obtain the same results as for big joint, hip and knee in terms of follow-up and level of failure. We talk about younger patient, but what is the definition of a younger patient with CMC1 arthritis? 3 years ago, for the National French meeting, we tried to answer to this question, and we defined 3 types of age: before 40, 40 to 50, and 50 to 60. But the level of activities may be quite different between a man or woman less than 40, working hard, playing tennis, and a man more 60 with light activities, doing, for example, only jogging. So at this stage, we must take into account the expectations of the patients in terms of return to the 3 activities who are work, sport, and hobbies. And we saw that this factor to return to activities was for this patient very, very important. So our conclusion was for this meeting, we tried to find therapeutic proposition. It's only proposition for this type of patients. And you see only the blue prosthesis, which is one of the proposition, and this table concerned DEL2 stage, and we can see that we reserved the prosthesis to light and medium activity. For DEL3 stage, it was the same thing. We didn't consider that the prosthesis for higher activities and hard activities, not depending on the age, was a very nice indication for prosthesis. So for this kind of population, we could define between 40 and 60 years. We have to answer to the question patient is asking. You know that when it be possible to return to work, to sports, and to hobby? And for us, is it possible to insert a prosthesis to do this proposition to the patient? So we have to hear the patient, show what he needs, and we have what he wants, and we have to talk to him to say, okay, this will be possible to do this. It will not be possible for us. And the conclusion of our round table was that the best indication for this population was light and medium activity, whatever the stage of 2, 3 of DEL. But this time we consider that there was no commonly reasonable to propose prosthesis before 40 and heavy workers. The return to work is the main questions of the patients. You can see that the patient after 2 months. We have to wait to return to activities of daily living. And you see there is, in this case, good difference, nice difference in terms of favor of the prosthesis, for the prosthesis in terms of return to work. This is for work and activities of daily living. And for the sport, there is the last, normally, last slide. Yes, return to sport. For me, no return to sport during 3 weeks. Sport without strength of the thumb during the 3 to 8 weeks, as jogging, swimming, and progressive return for between 2 and 3 months. And I consider there is no possibility to do fighting sports for these people, or there is another solution, you know, well, this. So in conclusion, I would like to say that for the younger patients, you know, you see 20 years ago, for Chakrabarty and Capel, it was not possible to insert prosthesis before 65 years. Actually, we are talking about 40 to 50, and I hope that in 10 years, there is a surgeon who said, you know, it's very funny. With the meeting of the Belgian Heart Congress, a French surgeon, Lucien, said it was not possible to insert prosthesis before 40. Maybe it will change in in 10 years. Thank you very much.
Yeah, thank you, Bruno, for sharing your experience and well-documented results of the prosthesis. I would like to call Professor Luc van Overstraten for his presentation about trapezius metacarpal denervation. Luc, it's up to you.
Thank you very much to Anne-Jeanne for this kind invitation. It's the beautiful Congress. Dear colleagues, I have pleasure to speak now about this specific procedure, selective CMC denervation. I have not the check of, yes, thank you. The story of denervation begins with German trends and the anatomic works of Redinger. In the following of total wrist denervation interest of Guy Fouché and also after the works of Buck-Gramco, Patrick Lauréat published the surgical technique to selectively denerve CMC joint. The long-term result didn't never present it. I don't use the double transversal approach initially described, but a parallel longitudinal dorsal and palmoradial approach. I think it's, for me, lesser inflammatory. The technique isn't demanding, but you need to follow precisely the stages. You are keeping in mind two important points. First of all, a complete adventisectomy of the radial artery on 25 millimeter and the removing of all components of pulse fossa. You have also to cut the deep recurrent joint articular nerve to cut the deep part of FCR sheet, and also you have to roughen the base of first metacarpal. You have to cut all branches from sensitive radial nerve. The second important point is the section of articular recurrent nerve at the first space. You have to ligature the anastomotic vein before to do that to avoid neuroma. The monooperative series is short, but you can see a long follow-up, a majority of blue collar and young people. I deplore that it was not possible to review all patients, but only 88%. The indication depends especially of the age, with 50% of patients in the 4th decade. The second indication is the status of the third, the contraindication for trapezectomy or prosthesis. As example, the scapholunate instability. You can see here the subjective functional results constantly good. The outcome of postoperative pain is particular and follow 3 steps. First is a complete disappearance of pain on 3 to 4th of the series during the first week, as a paradise indolencia for the patients. And it's is in fact the final result. The second step is a difficult and painful period of 6 weeks in a majority of patients that I attribute to the deafferentation of the nerves. Third step is an attenuation of the pain from the third month with a definitive result to last time after 1 year. Clinical results are characterized with excellent mobility without difference with contralateral side and a useful recovery of strength and pinch. The X-ray doesn't change at the longest follow-up. AX, interosseous space, sclerotic deformity, osteophytes are at moment of denervation, like if it fixed the arthritis in the majority of the cases. You see, no significant change after this long time. Sometimes you have a joint space narrowing with sclerosis or a deformation. We see 3 types of failures. The first is the persistence of pain immediately after procedure without this short period of indolentia. The second failure is a rapid recurrence after 2 or 3 years without really explanation. The third is a late recurrence by probably collateral reinnervation, but this is only for 35% of series. It is very surprising to note that after more than 10 years, 65% of these patients remain with very few symptoms. In conclusion, there are a really therapeutic interest of selective CMC denervation. The princeps indication is a young self-employed manual worker. This is a temporary alternative without cutting bridges and sometimes could be definitive. The efficacy of procedure is only on the pain. The preoperative clinical and radiological aspects are little or not modified. Thank you very much for your attention.
Thank you, Luc, for this interesting technique that maybe we should combine with other types of surgical treatments for trapeziometacarpal arthritis. We have 2 more minutes for questions and answers. Are there any questions raised? I don't see any questions coming in. Luc, I have a question for you. Do you sometimes combine denervation with, for example, placement of a prosthesis?
No, I don't combine this procedure because for me, the selective CMC denervation is a combination of a lot of section of nerve. When you do an CMC prosthesis, you do, of course, a section of the base of first metacarpal, and you have a sort of denervation, but it's not necessary for me to do a section of the branch of the radial nerve. It's not necessary to open the FCR sheets. because the indolencia from the prosthesis is complete and the CMC denervation is not necessary for me.
Okay, thank you, Luc. I would also like to thank the other speakers of this session, and then we are right in time to continue with the next session. Thank you.
There was a last question from Constantin Dressos. Why do you avoid any injection of cortisone in the trapezometatarsal joint? And second question, do you use acid hyaluronic injection?
You had a question for me?
Yes.
Yes, Jean.
I will answer the second question first and then the first question. Hyaluronic acid has proven its quality in shoulders and knees because we are confronted with a very large articular joint space with the recesses. We don't have any mechanical hyper pressure when we inject those products. But when you perform this in a discongruent small joint, you cause a lot of pain for the patient, which keeps on until the product has resolved completely. It is not an indication for me in trapeziometacarpal joint treatment, conservative treatment. Second, corticoids, and I have had this discussion with Alain Charles Mascalet, which I know pretty well, and he didn't understand why I didn't use corticoids. Corticoids are very bad for the joint, for the intact cartilage. They kill your cartilage. You should not use it whenever you still have some intact cartilage. That is an absolute contraindication. You can use it, and when I use it, I always tell the patient, or I use it in a post-traumatic setting where you have a persistent arthritis, which kills the patient, causing pain, and it can be useful once, just once. Or you can use it as the last straight line before surgery, because people want to postpone the timing for surgery.